I'm really pleased to introduce Dr. Annette Briley, who's a consultant midwife and who's into research. I'm not sure if we cut her in half whether we wouldn't find research all the way through her. And she's certainly at the moment really supporting research development within midwifery, and one of the very few midwives who have that sort of role. And she works at St Thomas's and Guy's Trust, and she's going to talk about early life nutrition. Have I got that right? I hope so, yes. So welcome, Annette.
Thank you, and thank you for the opportunity to talk to you today. So, as Sue very kindly said, I've been involved in research for a very long time, and in recent years it's been a lot about nutrition, and I'm part of an EU consortium looking at the fetal origins of adult disease, as well as having just managed a multi-centre study looking at a lifestyle intervention in obese pregnant women. So I know this is a bit of a crossover with the following speaker, but I hope to convince you, as I'm sure she will, that the first 1,000 days from conception to age 2 years is a unique window of opportunity to build healthier and more prosperous futures. Back to what Mary was saying about building Rolls Royces for the future. Preconceptual and nutrition from the preconceptual stage right until age 2 years influences lifelong health. It's required for brain development, for healthy growth, for strong immune systems. It is linked with a predisposition to obesity in childhood and adulthood, and also a predisposition to chronic diseases such as diabetes and hypertension. Globally, 49% of deaths in children under 5 is due to malnutrition. Virtually all of these are preventable. And it equates to 170 million children globally that are stunted either physically or intellectually by chronic malnutrition. As midwives, we must be aware that poorly nourished women are at greater risk of pregnancy complications. And damage caused by poor nutrition, both during pregnancy and in the early days of life, can be irreversible. And I'm sure when we think about the global situation, these are the images that come to mind. Areas of the world that suffer famine and displaced people. But I just want you, just for a moment, to think about the empty calories, the calorie-dense foods and nutritionally poor foods that we give our children and consume ourselves. Mary Barker was here this morning and was explained about her father's hypothesis, which he first proposed in 1990, that introduced uterine growth restriction, low birth weight and premature birth had a relationship with the origins of hypertension, coronary heart disease and type 2 diabetes in middle age. He didn't just dream this up, it was from registry data from the Dutch famine disaster and the Leningrad siege. The Dutch famine, both of these natural disasters are well documented in the literature, and it was apparent that women, the trimester at which the Dutch famine occurred influenced the outcomes for the babies, but also influenced the long-term health. The Leningrad siege was a much longer starvation episode, lasting about 800 days. So therefore, a lot of the children were starved, or their mothers were starved when they were in utero, but they also were starved in infancy. And they developed what he called the thrifty phenotype, so that some of the adverse health issues that were seen in victims of the Dutch famine disaster were not seen in the Leningrad siege. So what are some of these problems associated with low birth weight? There's an exponential catch-up growth which increases the risk of the metabolic syndrome in later life, which is obesity, insulin resistance, dyslipidemia and raised blood pressure. This catch-up growth leads to the visceral adiposity, the tendency to store intrauterine or the unhealthy fat, the sort of shape I am probably, where you store fat around your vital organs. And this is apparent very early on, and Mary said that they found it in children aged 4 in the Southampton Women's Study, but it's certainly been reported widely in children aged 5 to 11. And this increase in truncal obesity is also associated with elevated fasting insulin levels in fairly young children. And catch-up growth is undeniably associated with an increased incidence of type 2 diabetes in childhood, which a few generations ago we hardly saw. If we look at small for gestational age infants, and I've just put the two definitions here because I think there is quite a lot of confusion between what is intrauterine growth restriction and what is babies born small for gestational age. So small for gestational age is a birth weight less than the 10th centile for gestational age. Now, there's a lot of controversy around that, whether it's population centile, customised centiles, the WHO centiles, but it's a centile. Whereas intrauterine growth restriction is defined as a birth weight that is less than the predetermined genetic potential for that baby, probably due to a pathological insult in pregnancy. And the evidence is out there to suggest that both of those situations are associated with obesity, type 2 diabetes, coronary artery disease, hypertension, kidney disease, both in fewer glomerular filtration systems and poorly performing, premature puberty, polycystic ovarian syndrome, dyslipidemia, short stature and osteoporosis. So a pretty damning list. So if we look at the other side of the coin, if you like, the babies that are born large for gestational age, we know that they are predestined for future obesity both in childhood and adulthood, and they are also insulin resistant. They're less likely to receive breast milk. They have a rapid weight gain in the first 6 months of life, again, disproportionately like the small babies, and they have high blood pressure, they have hypertriglyceridemia, and they're predisposed to certain cancers, breast and ovarian in girls, prostate testicular in boys, and colon in both. So the preconceptual time is a really good time to address issues of excess weight, start a healthy lifestyle and diet, optimise health, start folic acid supplementation and iodine supplementation. If we look at the influence of parental BMI, in women, it reduces both low and high BMIs, reduce fertility rates, and has an adverse effect on the health of the human oocyte. It increases pregnancy loss and gestational diabetes, preeclampsia and hypertensive disorders, and obesity and diabetes in the child. But there is an influence of paternal high BMI in terms of impaired embryo and fetal development, reduced rates of pregnancy in the first place, and increased rates of pregnancy loss. Conversely, paternal undernutrition has been associated with increased body mass index in the children. So we're beginning to learn that there's paternal epigenetic changes in sperm that influence offspring health. If we look at pregnancy outcomes by BMI category at booking, you can see the pink is the normal BMI and the green is the BMI over 40. And this is from a meta-analysis done by Jodie Dodd's group in Adelaide. You can see that all the adverse complications are associated almost in a linear fashion with the classes of obesity, and the only thing that actually goes down is the normal vaginal delivery. If we look at the neonatal outcomes by maternal BMI at booking, again, you can see that the higher the BMI category, the more likely the child is to require resuscitation, to be admitted to the neonatal unit, to have a congenital abnormality, and it's also associated with perinatal mortality. And again, that's from Jodie Dodd's group. So it's really important to address BMI issues prior to conception. There have been several clinical trials now, large clinical trials, looking at overweight and obese women. There's the ROLO study in Ireland, the LIMIT study in Adelaide, and the UPBEAT study that we've done here in the UK. And we're using all of those data to do meta-analyses in this group of women. And all of them have come to the conclusion that the antenatal period is too small a window of opportunity to make a difference. Bearing in mind that around half of pregnancies in the UK are unplanned, that's very problematic for us. And NICE suggests that healthcare professionals should advise, encourage and help women with a BMI of 30 or more to reduce weight before becoming pregnant. So maybe they're even realising that it's too little too late. So going back to those healthy lifestyles preconceptually, we all know that giving up smoking, alcohol and recreational drugs is really important. Optimising health, so ensuring that pre-existing medical conditions are well managed and controlled, and making sure that the clinicians who are caring for women with chronic hypertension or diabetes know about their plan to get pregnant. and to start folic acid supplementation at least a month preconceptually, as it prevents open urotube defects, but at the appropriate dose. So women with diabetes, women taking certain anti-convulsants for epilepsy, and women, there is increasing evidence that women with a BMI over 35 should be taking 5 milligrams as opposed to 400 micrograms. So Phelan et al. Said that pregnancy was a teachable moment. But is it? Being pregnant provides a label. So for women who are watching their weight, or who are larger, or any size really, it's a time when actually it's a broader environment. Weight and weight gain is stigmatised. People do comment on how much weight a woman has put on or hasn't put on in pregnancy. So for a woman who is larger, who is used to having that kind of comment, she becomes like anybody else at that point. Women are very sensitive to barriers to change, and in pregnancy they have, obviously the larger they are, they're more prone to complications, but they're very tired. They don't feel like cooking or exercising. A lot of women complain that they have a lack of knowledge about healthy eating or physical activity, and particularly what is suitable in pregnancy. They lead busy, chaotic lives, and so time is always an issue. And they may, as Mary said this morning, identify a lack of support from their family in changing. There is a perceived higher cost associated with healthy eating, although several studies have shown that actually it's not any more expensive. And the lack of access to safe places for exercise, particularly in inner city areas. And if you look at the NHS Choices page, if a woman does go onto the internet and look about what to eat in pregnancy, this is the first page, foods to avoid in pregnancy. I think many women feel that what they're told in pregnancy is don't eat this, don't eat that, rather than do eat this. So if we look at the Eat Well plate, which seems to be the backbone of advice that is given, including an indication of portion sizes, this is what they state. It should be a third for energy, a third for fruit and vegetables, and in the other third, 60 to 100 grams of lean protein, and healthy fats such as extra virgin olive oil, and low-fat dairy products, and 1.5 litres to 2 litres of water daily. If you look at the referent nutrient intake for pregnancy, I'm very pleased to say that the old adage of eating for two does seem to be gone, passé. So obviously the micronutrient intakes that are required, obviously more folic acid, vitamin D, needs 10 micrograms, as opposed to none pre-pregnancy, and an extra 100 micrograms of vitamin A, and 6 grams of protein. But we only require an additional 200 calories in the third trimester. So what does 200 calories look like? 34 grams of peanut butter. Only 32 M&Ms. Very sadly, that's not a whole packet. A handful of Doritos, 10 gummy bears. We've got a research assistant who we work with who's always got gummy bears, and I'm sure I must steal at least 10 a day. 1,425 grams of celery, 496 mils of Coca-Cola, just over half a bagel, 4 additional slices of seeded bread, and 200 mils of tomato ketchup. We can't really talk about diet and nutrition without talking about activity, and this is from the RCOG website, and they say the advantages of activity and being active in pregnancy help adjust to the physical changes of pregnancy, may relieve tiredness, back pain, reduce varicose veins and swelling, improves muscle tone and strength and endurance, prepares for the challenges of labour, promotes a sense of well-being, reduces anxiety, stress and depression, improves sleep, may help prevent gestational diabetes and hypertension. But if you have got gestational diabetes, as with type 2 diabetes, exercise can help improve blood sugar levels, and its strength conditioning exercise in pregnancy can shorten the time in labour. In very real terms, certainly in my practice in London, I don't see very many women who will go swimming on a regular basis or who go jogging. So certainly in the Upbeat trial and with our women, we concentrate on them getting off the bus maybe a step earlier or taking the stairs instead of the lift, and just increasing that step count on a daily basis. If we look at gestational weight gain in pregnancy, the jury's really out. The NICE have concluded that there's no UK evidence-based guidelines on appropriate weight gain ranges during pregnancy. They refer to the Institute of Medicine guidelines in the States, which are there in the table. But they're all based on observational data And they show that women who gain weight within specified ranges had better outcomes than those who didn't. But they weren't validated by intervention studies, and they weren't large-scale trials either. So without that evidence from those, it's unclear to see whether adhering to those recommendations will lower the risk of adverse outcomes for mothers and their babies. And they conclude with, despite the Cochrane reviews and the HTA report, the panel did not feel there was sufficient evidence to change current recommendations. Then we move on to infant feeding. Obviously, the World Health Organization states that breastfeeding is an unequaled way of providing ideal food for the healthy growth and development of infants. It's also an integral part of the reproductive process with important implications for the health of mothers. As a global public health recommendation, infants should be exclusively breastfed for the first 6 months of life to achieve optimal growth, development and health. Thereafter, to meet their evolving nutritional needs, infants should receive nutritionally adequate and safe complementary food while breastfeeding continues for up to 2 years. If we look at the UK infant feeding survey, we can see the previous surveys are in pink and the current, or the most recent, which is data from 2010, is in blue, I think it is, black or blue. Unfortunately, they changed the way they asked the question. So in 2005 and 2008, they asked, did you initiate breastfeeding? And in 2005, 76% of women said they did. And in 2008, it was 81%. By 2010, they actually asked, did you exclusively breastfeed your baby at birth? And 69% of women said yes. That may be a drop, but it may be that if a woman had a baby that required additional fluids for phototherapy and just had some water, that she actually said no at that point. If we look at the breastfeeding at a week, in 2008, it was 69%. Exclusive breastfeeding in 2010 was 46%. So by a week old, less than half of women in the UK are exclusively breastfeeding their babies. At 6 weeks, it was 55% in 2008, but again, that use of that word exclusively meant it was 23% in 2010. And if we look at the WHO and compare these findings with the WHO recommendations, you can see that exclusive breastfeeding at 6 months in a UK population was 1%. Unsurprisingly, to probably everybody in this room, the women most likely to breastfeed were at least 30 years old. They came from black minority ethnic groups, Chinese 97%, black 96%, and Asian 95%. They tended to leave education late, being at least 18, have managerial or professional occupations, and live in the least deprived areas of the UK. So if you look at the benefits of breastfeeding, and I probably don't need to go through this really with this audience, there's a reduction in infections, particularly ear, lower respiratory and gastroenteritis. It protects against severe eczema, it protects against childhood asthma, and the longer the duration of breastfeeding, the greater the protection against non-atypic asthma. Reduces the risk of sudden infant death syndrome, and lots of studies have shown that breastfeeding has a positive effect on the child's general intelligence. It also reduces the chance of obesity, with a 15% decrease in the odds of being overweight in childhood compared with formula-fed infants. It also protects from type 1 and type 2 diabetes in the future. And for the mum, for her too, it reduces the risk of type 2 diabetes and the metabolic syndrome and cardiovascular disease. It reduces the risk of premenopausal breast and ovarian cancer and naturally uses up to 500 calories a day. Postnatally, obviously, mum has got to have a nutritious diet to help recover from the pregnancy and keep up with the demands of motherhood. So obviously, because she's built a baby, the calcium stores are depleted, so she needs to have a calcium-rich diet. Needs to consume omega-3s, which are critical for baby's brain and eye development, and obviously need to increase if breastfeeding. There's also some evidence to suggest that omega-3 plays a role in maternal weight loss. Needs to be eating antioxidants, so vitamin C and E, to scavenge free radicals, which prevent cellular damage in aging, cancer and other diseases. And antioxidants do pass through breast milk, so they will obviously have an impact on the baby too. Needs high B vitamins, which are important in carbohydrate metabolism, red blood cell formation, and build healthy nerves, and obviously increase water to maintain breastfeeding. And avoiding or limiting probably is more realistic, caffeine, smoking, and alcohol. I'm sure my health visitor colleagues here will know far more about this than me, but weaning usually is around 6 months. It's important to wait till your baby shows signs that he or she is ready for solid food, and NICE suggests that this is when the baby can sit and hold the head steady, when they have eye, hand and mouth coordination so they can pick up food and put it in their mouth themselves, and they're able to swallow food, noting that most first foods end up round the mouth rather than in the mouth. And they suggest first foods are things like mashed and soft cooked vegetables and baby rice with cereal or cereal mixed with the usual milk. It is acceptable to use cow's milk with food but not as a drink, and they suggest finger foods are soft ripe bananas or avocado. And then you're moving on to the next foods of cooked meat such as chicken, mashed fish, ensuring there's no bones of course, and then things like pasta, noodles, toast, lentils and rice. Babies aged from 6 months to 5 years will require vitamin supplements and vitamins A, C and D. By 8 to 9 months, we're moving towards 3 meals a day with a mixture of soft finger food, mashed and chopped foods, including fruit and vegetables, bread, pasta and rice, meat, fish, eggs, beans, and milk and dairy products, but not cow's milk. And by a year, should be on 3 meals a day, chopped if necessary, plus breast milk or cow's milk, and ensuring the child has healthy snacks of fruit, vegetable sticks, toast or rice cakes. They need a full fat dairy product as they need the extra fat and vitamins from full fat dairy. And each day require 3 to 4 serves of the starchy foods, 3 to 4 serves of fruit and veg, and 2 serves of meat, fish, eggs, dal or other pulses. Just a reminder of what failure to have good nutrition can contribute to, the so-called fetal origins of adult disease: diabetes mellitus, obesity and dyslipidemia, hypertension, coronary artery disease, stroke, kidney failure, glomerular sclerosis, liver failure, cholestasis and steatosis, lung abnormalities, reactive airways disease, reduced bone mass, Alzheimer's disease, depression, anxiety, bipolar and schizophrenia and cancer. So I would say between pregnancies, working with parents about the BMI is really important. There was a study about the impact of interpregnancy weight gain or loss on future perinatal loss. It was a huge population-based study in Sweden. They have amazing registries there with over 456,000 women. And they found that between 2 pregnancies, the work was done over 20 years from 1992 to 2012, 13.1% of women lost weight or lost enough weight to change BMI category between pregnancies. 45.9% had a stable weight, which meant they were within 1 unit of BMI either way between pregnancies. But over 41% of women increased their BMI by at least 1 between their pregnancies. And they found that if the women gained between 2 and 4 BMI points, which in weight is 6 to 11 kilos, they increased the risk of stillbirth by 27%. And if they gained 4 or more units of BMI, so they gained more than 11 kilos, the stillbirth rate went up by 60%. So overweight and obese women, conversely, who lost 6 kilos between pregnancies, reduced the risk by 50% of perinatal death. So in summary, like the next speaker, I'm guessing, I want to impress upon you that the first 1,000 days matters from conception to age 2. Thank you. I'd like to thank Tommy's who fund my post and Danome who we work with along with the EU Consortium. No, thank you.